Thank you very much. I just have a disclosure. I almost got fired a month ago. Our Minister of Health is a cardiac surgeon, and I operated on one of his friends, and I put a tricuspid ring on a mild TR. And when he called me asking, I told him the indication. He clearly told me that I don't understand anything in cardiac surgery. So I'll try to prove the opposite in this session. So I have no disclosure. And tricuspid valve repair, is the ring alone enough? I think the main question, tricuspid valve repair, do we do it enough? I'll share with you 3 cases that that triggered me to look into this topic and do a lot of research and adopt different methodology. 71-year-old female, she got a mitral valve replacement in 2014. At that time, she had mild TR, normal PA pressures, and mild RV dysfunction. 5 years later, developed severe TR, required admission to the CCU with severe right ventricular dysfunction, severe anisarca, congested liver. Radiosternotomy, tricuspid valve repair, over 2 weeks in the hospital, recovering from surgery requiring aggressive diuresis and close monitoring. Second patient, 70 years old, CABG in 2016. He had mild TR at that time. He had a lot of sternal dehiscence, required reconstruction. Anyways, he presented with progressive TR, progressive symptomatology, severe TR over 3 years. Right mini thoracotomy, tricuspid valve repair, stayed 2 weeks in the hospital. The last patient, 83 years old, mitral valve repair, 2013. Presented with severe right ventricular failure, generalized anisarca. Aggressive medical therapy did not alleviate the symptoms. TE, severe TR, elevated PA pressure, moderate RV dysfunction. So if we look at all these 3 cases, previous cardiac surgery, non-significant TR in the original presentation, all of them, they have progression of their TR and their symptoms are really bad. They require redo intervention. And if you noticed, the 3 of them have rough postoperative course. This makes me wonder about the documented mortality of tricuspid valve surgery. It would be between 8 to 30%, which is really high for such simple operation. And if you look at this study that came from Korea, they look at the distribution of this patient, and the main reason for mortality is not because it's a technical operation or because of the etiology of the valve, because we operate too late on these patients. So the question here, wouldn't it be easier to tackle the tricuspid valve in the first operation like I did in the case that I mentioned at the beginning? And if we do, but on the contrary, why to do so if the tricuspid valve looks normal or the TR is less than severe? This is an alarming data from Song, where he looked at the progression of the TR. He looked at around 650 people, and 7.3 of none to trace TR developed moderate to severe TR at 5 years, and 20% of mild TR developed severe TR. I don't know if Patrick Paesi here, I watched his lecture that he did in 2011 at the Society of Cardiothoracic Surgery, and he stated very clearly in this slide that the RA, the tricuspid valve, the RV are the most superficial structure of the heart, and so does our knowledge about the tricuspid valve and its pathologies. That triggered me to look into our Bible of cardiac surgery cones. I look at the chapters that are written about aortic valve. Look how many chapters. Look at the mitral valve. Look how many chapters are written about the tricuspid valve. Only 4 chapters. And then I went into the literature. I look at the publication on different valves. Close to 1,000 about the aortic valve. I'm sure it's more now. 500 in the tricuspid valve. And 200 with only 2 RCTs about the tricuspid valve. So forget about the textbook. Forget about the literature. Let's go to the gurus and the consensus in cardiac surgery. In one of the mitral conclave in New York, David Adams said he does 20% tricuspid valve repair during left heart surgery. That's too little. On the other side, David Adams argued that he does 80% when he does a left-sided valve. So he does too little, the other one does too much. And that's why, because we don't have enough data, that's why our guidelines are shy enough to put a clear indication for tricuspid valve surgery. And most of us kept believing that dogma that came from this patient that was published in 1967. In majority of patients with secondary TR, surgical treatment of left-sided valve correct the problem in the right side. It did not happen in the first 3 patients that I presented. And we all make it sounds like the RV is the annoying companion of the left-sided pathology. And I don't think that's true. If you look at the survival of TR, look how much TR impacts survival. It depends on the severity, but all degree of severity affect survival. And I showed you how it progressed in the first paper. This is another study, prove the same. Here, they look at the TR and they isolated different confounders, and it just tells you the same thing. TR is a bad pathology and need to be addressed in a better way. But why do we have TR? Most of the time, it's functional. 80% of the patient, it's functional, and 15 to 20%, there is a lesion in the tricuspid valve. Most of the functional problem is annular dilation, there's no good coaptation, and leading to CVR, which progress, the RV would dilate, the annulus would dilate more, and then you will have increasing severity of TR. People did a good studies and trying to understand where does the annulus dilate. And if you notice, it's mostly dilates in the anterior posterior, anterior posterior annulus, sparing the septal part of it. And this is a blessing for us and hinting to us that it's okay to repair because the conduction system is away from where you need to put your stitches. So why do we need, and what are the indications and how? This is maybe the first randomized single RCT that come from Jibril Khouri. And if you look on the left side my slide, the progression of TR is less in people who got annuloplasty. Look on the right side, many patients progress to severe TR. So prophylactic annuloplasty prevented the progression of TR, and I think helped the survival of those patients. This is a recent trial that came from multi-centers. I hope Michael Chu was here. And the only downside of doing a tricuspid valve is the increased pacemaker rate. But how much pacemaker you saw of that tricuspid valve intervention on your hands? I don't think it's 14%, to be honest with you. And if you look at the guidelines, so severe TR, left-sided valve surgery, class 1, mild to moderate, you look at the annulus, more than 4 millimeter or more than 21 millimeter. You need to do about it, but there is no strong indication for that. Where does the 40 millimeter and the 21 came from? Gil Griffiths did a lot of work. He measured the anterior septal diameter, 7 millimeters. Parlos, on the other hand, stated very clearly in his latest publication that TR is most likely or partly or mainly organic. And he put some sort of guidelines, dilated annulus more than 21, dilated RV, RV overload, pulmonary hypertension. So if you have all of this, you need to fix the tricuspid valve. So the threshold of 40 millimeter annular dilation, where did it come from? No clear number. It's actually not easy to measure, even with 3D echo. But as these French philosophers say, I'm sure Walid knows him, nothing is firmly believed as which is least known. So can we challenge this fact? This study looked at normal tricuspid valve dimensions and annular diameter, and there are people who are normal people walking in the streets with an annulus of more than 40 millimeters. Tyrone David also challenged this fact, and he said 40 millimeter is not a predictive of development of post-operative TR. And pre-operative TR was the strongest predictor of post-operative TR. And he stated this, which somehow it's a precise statement. He said, look at the amount of leaflet you have in relation to the annulus. If you think there is enough leaflet to provide good coaptation, you don't need to do annuloplasty. If not, you need to do annuloplasty. But when we deal with rheumatic in our ward, usually those leaflets are retracted and there is annular dimension, so I think our threshold is even lower. All what I can say now that tricuspid valve regurgitation is a complex pathology. It needs a comprehensive assessment, look at all the factors and make an informed decision, but don't assume it's going to improve with the left-sided correction. So is the ring enough? I think the two factors, as Tyron David hinted in his paper, look at the annular dilation, look at the amount of the tissue to provide coaptation and their quality. And then you can judge whether undersizing is enough or not. If you look at the stages, the first two stages, annular dilation and then annular dilation with some leaflet, lack of leaflet to give you good coaptation. I think the first two stages, yes, you can correct them with an annuloplasty ring, but the last stage, I don't think reduction annuloplasty is enough. The procedure itself, it's simple. That's usually the first valve that we touch during training. There is nothing much about it. This is a redo operation, and as you can see, there is no magic in correcting the tricuspid valve. You just few stitches, put it down. I'm even more lazy these days. I don't tie it myself. I just cinch it down with core knots. I don't think there is anything special about this. If you need to do some more work, do. And if you have acceptable result, you don't need to achieve 100% competent valve. On the other side, if those patients present late, there's not enough tissue to provide coaptation. You need to do something more than just reduction annuloplasty. And again, look at the amount of tissue, look at the annular dilation. I don't think reduction annuloplasty will solve the problem. So what you need to do here is to add some leaflets, and this is described by Gildreffes again in his paper, where he take an autologous pericardium and he augment the anterior leaflet to provide a good level of coaptation. It's a simple and straightforward operation. This is how it looks on the diagrams. So I think the take-home message here is don't wait when it's too late. It takes you 10 minutes, 10 stitches, and it's on your way out from the heart. And I start doing it on my minimally invasive cases, and it doesn't add a lot of complexity to the patient. I don't think we should wait until the patient presents with an SRCA, right side failure, pulmonary hypertension, and edema like this. Those patients, they take a long time in the hospital and they need a lot of complex care afterward. I'll just go with my favorite sport brand and I'll say just do it. Don't wait until too late. Thank you very much.